So, during my talk this morning, what I tried to emphasize is the fact that when we deal with patients with diabetes who are relatively young, perhaps less than 35 or less than 30 years, we need to have a very broad differential diagnosis. It's not just type 1 or type 2. Beyond that, the investigations need to be comprehensive. So when you have a person who has young onset diabetes with a very strong family history, we need to think of genetic disorders. One of them being maturity onset diabetes of the young. But that's just one. And there are many other undifferentiated forms of young onset diabetes which are there. And currently with technology which has evolved over the last 5 to 6 years, we have this technique called next generation sequencing or NGS. And what next generation sequencing can do is you can line up to 30 to 40 genes at the same time, of course with good technology and a good scientist, and try and make a diagnosis of a single mutation or a double mutation in a particular condition. What NGS has done is that it's been able to cut down the cost in making diagnoses of certain disorders almost 200-fold. So something which would have cost something like maybe 1.5 lakhs for 3 genes will today cost something like 12 or 13,000 rupees for 35 genes. The turnaround time and the throughput is much more rapid. You can get an answer within about a month. But once again, let me emphasize, it's all about not just technology, it's about good scientific brains, and it's also all about a good family history, a good pedigree chart, and a good interaction between the scientist and the clinician. The second part of my talk was all about mechanisms of diseases like fibrocalcitic pancreatic diabetes. And what is surprising, it might seem evident, and it is true that insulin deficiency is common and is a major factor in the evolution of the disease. But what came as a big surprise was that they do have excessive glucagon production. And we really don't know the reason for this. We are continuing investigations in this particular area to figure out what's happening. We have one particular category of lean diabetes, what was called malnutrition modulated diabetes about 2 decades back. It was on the WHO classification. It's no longer there, it's been taken off, but it still very much exists in lower socioeconomic classes and rural areas of India. What the founding fathers of this particular condition thought was that it's largely an insulin resistant condition. In our group, we have found out quite clearly that it has an association with strong insulin deficiency. There is insulin resistance at the level of the liver and also some peripheral resistance in addition, but it's largely that of insulin deficiency. So let's put all these things together and we say that when you see a person who is young with diabetes, do a few simple tests. You need to get a very good pedigree chart and a very strong family history. Look for dysmorphic features. Take an ultrasound of the abdomen or a CT scan to look for calcification in the pancreas. Measure C-peptide levels in the fasting and the postprandial state. And in addition to that, if you have any doubts in terms of a potential genetic testing, then you should resort to referring those samples to a center which has the capacity to do next generation sequencing.